a walkthrough. Mr. DeBasio, and then I will invite you to formally introduce yourself and your team. So good afternoon. This hearing is being convened for the limited purpose of hearing oral argument in docket number 22-32612. The applicant in this matter, Johnson Memorial Hospital, seeks to terminate labor and delivery services. On January 16th, 2024, the hearing officer in this matter issued a proposed final decision denying the application. On February 2nd, 2024, the applicant filed a brief in opposition and written exceptions to the proposed final decision and requested an opportunity to present oral argument. On February 7th, 2024, the Office of Health Strategy issued a notice of oral argument for today. This hearing before the Office of Health Strategy is being held on March 8th, 2024. My name is Deidre Gifford, and I'm the Executive Director of the Office of Health Strategy, and I will be issuing the final decision in this matter. Also present on behalf of the agency is OHS General Counsel, Anthony Casagrande. OHS is holding this public hearing remotely by means of electronic equipment. Any person or who participates orally in an electronic meeting shall make a good faith effort to state his or her name and title at the outset of each occasion that such person participates orally during an uninterrupted dialogue or series of questions and answers. We ask that all members of the public mute the device that they are using to access the hearing and silence any additional devices that are around them. This hearing concerns only the applicant's oral argument regarding its brief and exceptions to the proposed final decision, and it will be conducted under the provisions of Chapter 54 of the Connecticut General Statutes. The Certificate of Need process is a regulatory process, and as such, the highest level of respect will be accorded to the applicant and to our staff. Our priority is the integrity and transparency of this process. Accordingly, decorum must be maintained by all present during these proceedings. This hearing is being transcribed and recorded, and the video will also be made available on the OHS website and its YouTube account. All documents related to this hearing that have been or will be submitted to OHS are available for review through our electronic Certificate of Need portal, which is accessible on the OHS CON webpage. Although this hearing is open to the public, only the applicant and its representatives and OHS and its representatives will be allowed to make comments. Accordingly, the chat feature in this Zoom call has been disabled. As this hearing is being held virtually, we ask that anyone speaking, to the extent possible, enable the use of video cameras when speaking during the proceedings. In addition, anyone who is not speaking shall mute their electronic devices, including telephones, televisions, and other devices not being used to access the hearing. Lastly, as Zoom has notified you, I wish to point out that by appearing on camera in this virtual hearing, you are consenting to being filmed. If you wish to revoke your consent, please do so at this time. However, please be advised that in such event, the hearing will be continued to a later date. We will now proceed. Counsel for the applicant, can you please identify yourself for the record?
Thank you, Madam Director. My name is David DeBasio. I'm an attorney at Hinckley Allen, and I'm counsel for Johnson Memorial Hospital. With me here today are Dr. Robert Roos, the Chief Administrative Officer of Johnson Memorial Hospital, Claudio Capone, the Regional Vice President of Strategic Planning and Business Development of Trinity Health of New England, and my colleague Anna Gurvich of Hinckley Allen as well.
Thank you. Are there any other housekeeping matters or procedural issues that we need to address before you start, Mr. DeBasio?
I don't believe so, Madam Director. We have not moved to supplement the record, and we have tried to make sure that our brief and our argument rely only on the submissions that have already been made to the hearing officer for the proposed final decision. And if I mentioned something outside the record, it's inadvertent and I probably misspoke. It is not an attempt to introduce new evidence in this hearing.
Understood. Thank you very much. Mr. Casagran, anything from you before we start?
No, I think Attorney DeBasio's representation suffice. Thank you.
Okay. Thank you. All right. You may begin whenever you're ready. Thank you.
Thank you, Director. At the outset, I would like to first just start by thanking Hearing Officer Novi and her entire staff that conducted the underlying hearings that led to the proposed final decision. It was a pleasure to work with them. They were professional, they were courteous, and while we disagree with some of the findings that were in the proposed final decision, we have nothing but the utmost respect for her and her team and do appreciate the way we were treated by all of them. So to begin, over the last few years, Johnson Memorial Hospital has experienced a declining number of births, as increasingly a significant number of expecting mothers in the Johnson Memorial Hospital service area have chosen to deliver at other hospitals. In addition, the number of overall births in the community has been in consistent decline year over year as a result of a graying demographic. Low patient volume creates an environment in which it is difficult for providers to maintain clinical skill sets, making it harder to recruit and retain qualified and trained nurses and other staff, making the safe operation of labor and delivery services an ongoing challenge. Labor and delivery volume at Johnson Memorial has declined from 302 deliveries in 2008 to an average of 172 deliveries annually between 2017 and 2019. Even with the lower volume, any hospital is required to maintain certain levels of clinical staffing and resources to safely operate an inpatient labor and delivery unit. This includes having 24/7 physician and 24/7 nursing coverage. The services provided at the higher cost facilities, such as Trinity Health, reflect specialized resources for higher acuity and more complex patients. Those services were never available at Johnson Memorial Hospital. Dr. Roos testified in the underlying hearing that a service provided at St. Francis, and I quote, a service provided at St. Francis that could not be provided at Johnson because a mother needed a higher level of care or a baby needed a neonatal intensive care unit would considerably drive up the overall cost for labor and delivery services at St. Francis, which wouldn't be a comparison to Johnson because those mothers would always be delivering at St. Francis and not at Johnson. As Johnson Memorial stated previously, given the complexity of cases St. Francis is equipped to deal with, St. Francis regularly deals with a larger cohort of patients that need specialized care. For example, the neonatal care Dr. Roos referenced, or multi-birth deliveries, driving their average cost numbers up significantly higher than those at Johnson Memorial or Mercy Medical. These numbers include the cost of treating both the mother and the infant in acute cases for services which are not and have never been offered by Johnson Memorial Hospital. Patients with higher acuity cases choose to deliver, and if needed, are transferred by Johnson Memorial Hospital to deliver at facilities with higher acuity resources. The higher average cost for these facilities reflect higher acuity and the increased complexity of these cases. OHS in their proposed decision agreed that when Johnson Memorial had a labor and delivery unit, it did not deliver high-risk pregnancies and did not have a neonatal intensive care unit. This is important to the determination today that OHS is tasked with because the proportion of higher risk pregnancies is also accelerating nationwide and is a top national trend, in addition to accelerating in the proposed service area. Johnson Memorial Hospital has demonstrated that this fact is reflected locally in our primary service area, with more than 80% of the deliveries occurring from Johnson Memorial's primary service area taking place at other hospitals with better resources to serve higher acuity cases, a fact which OHS has acknowledged in its proposed final decision. There is additionally a recognized public need for post-delivery care, for pre and post-delivery care. This coincides with what Johnson Memorial has been transitioning to do and with the stated mission of OHS, which is to implement comprehensive data-driven strategies to promote equal access to high-quality healthcare, control costs, and ensure better health for the people of Connecticut. OHS's planning and regulatory responsibilities are intended to increase accessibility, continuity, and quality of health services, prevent unnecessary duplication of health resources, and provide financial stability and cost containment of healthcare services. And OHS has correctly determined in their proposed final decision that Johnson Memorial's proposal to close labor and delivery here aligns with the overall state's plan and goal of quality services. Johnson Memorial established the closure aligns with that plan and is set forth in Section E of the proposed decision. Johnson Memorial respectfully disagrees with OHS's finding on page 15 of the proposed decision that it's expressed greater need in the primary service area for more wraparound services like pre and postnatal delivery should not be considered in the application's determination. One of OHS's burdens in evaluating whether any CON application should be granted or denied is considering whether the applicant has satisfactorily demonstrated how the proposal will improve quality, accessibility, and cost effectiveness of the delivery of healthcare in the region. As the hearing officer concedes in the proposed final decision, these wraparound services that we're referencing are useful to the community and should be a factor in OHS's decision-making process. These wraparound services meet all of the touchstones we just discussed. They improve quality, access, and the cost effectiveness of healthcare delivery in the primary service area in a way that maintaining labor and delivery services in Johnson Memorial Hospital would not. Dr. Roos testified that closing labor and delivery, a service which has experienced chronic issues with staffing, would improve access to care, both pre and postnatal, and would be cost neutral to the vast majority of patients in the primary service area. And to quote Dr. Roos, the enhancements of the prenatal and postnatal delivery services will be what really increases health outcomes and health equity in the region. Studies show that the value of having access to a well-organized, high-quality array of resources and programs is how we decrease health disparities. That is exactly what Johnson Memorial's proposal would do in terms of closing labor and delivery, which is an underutilized service at the hospital, and shifting and transferring those resources to these pre and postnatal services that are detailed in much greater depth in our original and our supplementary brief. And I want to stress, and I think the record supports this, that this is not a cost-cutting measure that Johnson Memorial has taken. It is not a measure to lay off staff. All of the people that have been trained, and the record reflects this in our appearances before OHS, have either accepted positions at Trinity Health or at other hospitals and were offered positions at Johnson Memorial, but chose not to come there. What we're talking about in switching to these wraparound services is giving nurses and doctors an opportunity to be fully utilized to touch patient lives both pre and post-delivery in a way that has a positive impact on these high acuity and, quite frankly, on normal births. Dr. Roos has testified that the overall cost of the state healthcare system is anticipated to improve with the closure of labor and delivery at Johnson Memorial, since there are concurrent initiatives, as I just discussed, in place to transform Johnson Memorial Hospital to address the growing needs in that service area. By addressing the services with higher demand sooner, one of the overall goals and one of the overall results is to care for and work with patients to maintain and lower the acuity of their healthcare needs and lead to better results. This community care is anticipated to ultimately lower the overall cost of healthcare for patients and the healthcare system in the years to come. It is uncontested that there is an aging population in the primary service area, a trend of higher risk births and a year-to-year over decline in birth rates. The population in the primary service area are better suited to the wraparound services that we've discussed than an underutilized labor and delivery unit that cannot provide the specialized resources such as a neonatal intensive care unit that patients would have available at higher volume hospitals. Dr. Roos has consistently testified and given supporting evidence that this proposal will save patients cost and improve the quality and access to care. And he's further testified that looking simply at the charts that we've seen relied on in the proposed final decision and comparing the costs of Johnson Memorial Hospital to these higher acuity hospitals in a vacuum is inappropriate. Those other hospital costs cited all provide treatment for high-risk births, higher acuity outcomes, neonatal intensive care units, and there is no dispute that Johnson Memorial has not and has never dealt with those types of patients. Therefore, costs at those facilities must be higher, which is what's reflected in the documents. For the last several years, due to the low patient volume and labor delivery in Johnson Memorial, Johnson Memorial has been unable to recruit and retain a nursing staff in sufficient numbers to reach the target full-time employees for adequate staffing and coverage. The inability to achieve the target full-time employees to safely provide 24/7 coverage caused Johnson Memorial to suspend its labor and delivery services while they were actively trying to recruit additional nursing staff. While Johnson Memorial was unable to reach these targeted levels of staffing despite its substantial recruiting efforts and the cooperation of St. Francis and Trinity Health in terms of onboarding and training these nurses. As a result, the public would not be well served and should OHS find Johnson Memorial must continue to offer these labor and delivery services as the need in the community for the services declining, coupled with the challenges in achieving staffing levels, we would reach a situation where the costs are unsustainable given the utilization. OHS acknowledged Johnson Memorial's efforts to recruit and retain providers in its proposed decision, and we agree with that. Johnson Memorial is simultaneously in the process of expanding its locations in Enfield to include community access to services such as OBGYN and women's health specialties, primary care, imaging, and laboratory services. The infusion of these additional services into the primary service area supports the improvement of health equity and will continue to be the focus of the Trinity Health of New England system. Instead of dedicating extra resources to maintain an inpatient L&D unit that historically has been underutilized, with one delivery on average every 2 days, despite the need for 24/7 staffing in order to reopen the service, leading to an underutilized nursing staff, the community resources we're talking about with these wraparound services will create full-time utilization of staff in the community, providing critical healthcare services accessible to these patients on a daily basis in the community. Finding Johnson Memorial can discontinue a service due to the low utilization of the service, and Johnson Memorial's inability to retain staff would better serve the public need for safe and high-quality labor and delivery services, as the proposed final decision has found. I'm happy to answer any questions or provide any further information if the hearing officer requires.
Thank you very much, Mr. DeBasio. I don't have any further questions. I've reviewed your brief and the record. I have the information that I need to issue a final decision. Tony, do you have any additional questions for the applicants? You're muted.
We've all done it. You're still muted, Attorney Casagrande.
I think he said no, he has no additional questions.
Thank you, Madam Director, and
Can
I
you hear
should
me
add.
now?
Yeah.
Yeah, I apologize. I couldn't find the button. I'm usually using Teams, but I don't have any questions. Thank you.
Thank you.
Thank you, Madam Director, and I should add just in closing, which is not part of our formal argument, but Johnson Memorial is always available to discuss, alternatives with OHS should they desire to. It was never our intention to get into a litigious position with OHS because we see us as cooperating in terms of providing the best health care that the citizens of the state of Connecticut deserve. So to that end, if there are any other further discussions that need to be had in the future, we would certainly be available for that.
Okay, duly noted. Thank you very much, Mr. DeBasio. Thank you, Ms. Garovich, Dr. Roos, Mr. Capone, and everyone else. Thanks to the OHS team. With that, thank you very much for attending today. I will be issuing the final decision in accordance with Chapter 54 of the General Statutes. Have a good afternoon, everyone. Thank you.
Thank you, Madam Director.